Good afternoon. This is Karen Kennedy with the Indiana Hospital Association, and I serve as Vice President of Quality and Patient Safety, and I want to welcome you to today's Improving Care Transitions Among Multiple Care Providers in the rural setting. So, with this, we're going to just do some housekeeping real quickly. Right now, I'm going to have Shelby just go through a roll call of the hospitals that we're anticipating having on the line, and then we'll have just a couple minutes if any long-term care and EMS providers are with us. Go ahead, Shelby.
All right, so just let me know if you are on the call for your organization. So Bluffton. Cameron Memorial.
Yes.
Okay, great. Decatur County?
Yes.
Yes. Great, thank you. DeKalb? No DeKalb? Okay. Franciscan Health Crawfordsville?
Yes.
Great, thank you. And Rensselaer? Okay. Gibson General? No Gibson. Okay, Greene County. No Greene County. Henry Community. Okay, no Henry. IU Bedford Hospital.
Yes.
Great, thank you. IU Blackford. No Blackford. Okay, IU Frankfort. No Frankfurt. Okay. IU Paoli?
Yes.
Great, thank you. IU White? Margaret Mary?
Yes.
Great, thank you. Parkview LaGrange? Parkview Noble? Parkview Wabash? Putnam County? Rush Memorial? Scott Memorial? St. Vincent Clay?
Here, this.
Great, thank you. St. Vincent Dunn?
Here.
Great, thank you. St. Vincent Randolph? Sullivan? Okay, and Union Hospital Clinton.
Okay. Thank you, Shelby. And for anyone who we may have missed or you joined on just a couple minutes late, if you could chat in that you're here, that would be helpful. Do we have any long-term care providers or EMS on the line today with us?
We have Morning Breeze in Greensburg, which is long-term care.
Okay. Wonderful.
Decatur County EMS.
Appearing Care Angola is on. We were formerly known as Lakeland Skilled Nursing and Rehab in Angola.
Great. Well, wonderful. We're glad to have a few of our partners outside of the hospitals with us joining today. So we are planning to keep this call unmuted unless we do hear some background noise. We will mute everyone, and we will leave time for questions and answers at the end of our discussion here. If you have any questions throughout, though, the dialogue, please feel free to chat in. We'll be monitoring that throughout the call today. So just so kind of everyone understands kind of where this project is coming from and where it's being funded. So this project is funded through the Indiana State Department of Health Small Rural Hospital Improvement Grant Program. It's also known as the SHIP. And so with that, any hospital that was eligible in Indiana was able to sign up for this project, along with there's 5 other SHIP projects that the Indiana Hospital Association will be facilitating throughout this year. So we are here today to kick off this Care Transitions project. It's one I think it's going to be really exciting, and I think it's going to be something new. Not that Care Transitions is a new topic, but I think in the area of looking at a very specific quality improvement project where you're looking at a triad. So we're asking, and we'll get into details of this, for each participating hospital to partner with a long-term care facility, skilled rehab facility, nursing facility, as well as an EMS in your community, and then work with us through this quality improvement project. I just want to keep in mind that because this is new, I guess I can say that we're considering it a pilot project. So we recognize along the way that that we're going to have a variety of different levels of where a hospital has worked with maybe its EMS in a quality improvement project, or a nursing facility with a quality improvement project, and maybe there are some communities that are way ahead of in the spectrum of this, and I have already been doing some quality improvement work with all 3 types of organizations. So we recognize that there could be some that will be very far along, and we'll probably even be reaching out to you as mentors in this project. And then there's going to be some that are probably going to you're going to need more coaching. And please know that, the IHA team, as well as our partner that I will be introducing, the Center for Patient Safety, will be available to help you through that process. So keep in mind again that we consider this a pilot. So really just the purpose of this project is really to provide training and tools for small, rural, and critical access hospitals, again, long-term care and EMS staff, to support transportation and care transitions for patients with chronic disease. And specifically, we're going to be looking at respiratory, such as COPD. And then we'll get into more details of the objectives in just a few moments. This is considered the kickoff project, the kickoff of the project, and it will be a project that we'll be working on through May of 2019, and then there is some possibilities that this is a project that we could continue further into 2019. So without further ado, I'm going to turn this over to Tina Hillmetz from the Center for Patient Safety. And I recognize that's a very close name to what you're seeing on the slide, or hopefully you're seeing on your screen, which is the Indiana Patient Safety Center of the Indiana Hospital Association. But we are different organizations with similar names. We actually came into existence around the same time. But the Center for Patient Safety is based out of Missouri. They've been dedicated, just as IHA and IHA's Indiana Patient Safety Center, to promote safe and quality health care through the reduction of medical errors, and has been focused on its goals on integrity, advocacy, excellence, and culture of patient safety. We really are bringing this partner along because of their expertise in working with EMS. They've done a lot of work in the quality improvement and culture of safety with EMS, and they also have experience with long-term care as well as hospitals. And so I think they're going to be a good complement to the expertise that IHA brings to the table in this area, and will be a good partner for us. So again, we will, I think we do have maybe the phones on mute right now, but if you have any questions as we go through this, again, please feel free to chat in. And if you missed the roll call, if you could go ahead and chat in your hospital name or even your EMS or your long-term care provider name, that would be great as well. So without further ado, I'm going to turn it over to Tina. And Tina, I'm going to now share the screen with you. All right. I think you have that. You have control now.
All right, can you see my screen?
Yes, we can.
All right. So, as Karen mentioned, this was her, the Indiana Patient Safety Center mission is to engage and inspire healthcare providers. We've really already talked a little bit about these first few slides, so I might go kind of quickly over the first few. The agenda for today is I'm going to talk a little bit about who we are at the Center for Patient Safety. I'm going to review or highlight the objectives and overview of the project, then go through the 3 different phases we're going to implement for this project, and then kind of more go into a very, very high level as to why this project. So without further ado, the Center for Patient Safety, as mentioned by Karen, we are a patient safety organization. We are independent and not-for-profit, established in 2005. We develop patient safety and quality resources and services for hospitals, health systems, ambulance services, physician offices, nursing homes, and home health and hospice. Our mission is centered around reducing preventable harm with the values of integrity, culture of patient safety, excellence, and advocacy. We work with organizations across most of the continental United States. I want to say I believe we're in 44 different states right now. So what we do, we focus around learning, protecting, and preventing. We feel that you need to learn where you need to improve your organization by implementing culture solutions. And we do this by administering the Safety Culture Survey. For hospitals and long-term care facilities and medical offices and ASCs, we administer the SOP, the Survey on Patient Safety. For EMS agencies and then also home care, we have developed our own survey for measuring patient safety culture. And the EMS survey, we just recently had validated and put forth and have been really working with a lot of EMS agencies across the United States and helping them to take the survey so that they can identify strengths to help work on weaknesses. We also have worked with collaboratives in promoting the CUS program. We have 3 Just Culture certified trainers on staff. We also have, I believe, 3 Team Steps Master trainers on staff. And then twice a year, we work with the University of Missouri with one of the developers of the Second Victims Program, Dr. Sue Scott, and we put on a Train the Trainer workshop twice a year. We then think that through protecting, as we are a patient safety organization, you can then protect what you're doing through working with a federally designated patient safety organization. And then lastly, prevention, we see knowledge as power. And so by promoting and providing educational tools, we feel that you can remain up to date with all the latest information regarding patient safety and best practices. So Karen mentioned that the project overview, what we're really trying to do is provide training and tools for community members, for hospitals in rural areas, long-term care facilities, skilled nursing facilities, and EMS agencies that would help support the transition of high-risk patients. And this project is really going to focus in on those that have chronic diseases such as COPD. And then we're also going to look at respiratory compromise that goes along with COPD. We're hoping to increase, or for those of you maybe who haven't really been introduced to the concept of shared accountability or just culture, we're hoping to increase your knowledge base. And then we're going to work with you to develop and share communication tools and techniques to help ensure a smooth transition. And as Karen mentioned, we understand that many of you will be at different points along this journey, we call it, of culture and communication. And so I really hope as we go along that those of you who are a little bit further along and already have developed some best practices are really willing to share those concepts that you've developed and also share how you got to the point where you are and try and be maybe mentors for those who are just starting out on this journey. So phase one, or the kickoff, introduction, and also kind of the recruitment time, is we're going to be distributing more detailed information regarding this project. It gives us the time to get to know who you are. We are going to open the opportunity for anyone to take the SOP survey. So for any skilled nursing facility that hasn't taken a SOP survey recently or has never taken one, we're going to encourage you to go ahead and take it. If you don't take it in October, we're going to offer it again at the end of the project in March. For any EMS agencies who are on the call and are interested, again, we're going to be sending out some information sheets and contact sheets. So if you would be interested in taking that culture survey in October, you'll be able to reach out to us and let us know. And again, then we will, if you don't want to take it quite yet, you want to get more involved in the project first and want to wait and take it maybe in March, that's fine too. We thought we would offer it a couple of different times. We're going to either review or introduce you to culture and the role that culture of an organization plays in driving quality care. We really do want to engage the community partners. And then we have like a community board or a community forum, and we're going to open up our membership area to all of the participants, and we're going to have a community forum where you can go in and like virtually talk to people and start conversations. And I'm going to try to use that forum to not only provide materials, I'm also going to be sending it to the Indiana Patient Safety Center so that they can use their SharePoint that they have with all of you to distribute materials. And then we're also going to have them in our forum. But it's an area where hopefully we can get some conversation maybe going. And so the activities in this beginning part is not only going to be the SOP, but it's also going to be recruitment. I realize that while some of you do have those relationships already going, there might be a handful of you that really don't know how to go about reaching out to your EMS agencies or long-term care facilities in your area. And so some ideas to think about are, you know, look back at some of those skilled nursing facilities that you discharge to, and who seems to be the one that you discharge to most frequently? Who are the EMS agencies that you contact to pick up your patient? Who are the EMS agencies that bring patients into your facility? So start thinking about these and who you might want to reach out to if you haven't yet. So a lot of that recruitment is going to be going on in October, as those maybe who would like to take the survey are also getting set up to take the survey. In November, we're going to do a webinar, because even those hospitals that have already taken this up, we're going to take your results and put them into our feedback report. And so then in November, we're going to do a webinar on how to read those feedback reports. And then we're also going to do a high-level overview then of culture at that time. So then phase 2 starts in December, because we figured we'd do the webinar on the SOP and the culture survey in November, let you all have a really great Thanksgiving, eat lots of food, and then we can come back and get right into the main component of this project, which is the implementation. And that will run from December of 2018 with the first webinar through April of 2019. During this time frame, we're going to have a total of 6 webinars. There's going to be 3 clinical and 3 cultural. And then we're also going to do in-person patient safety forums. And we're going to do them at the, we're going to kind of break up the state so that nobody has to drive really far, but yet we can reach people in all areas of the state. So we're going to do one in the northern area, central and southern area. And by this time, what I'm hoping to do is, especially through the community forum, through emails, through getting a registration list, reaching out to all of you, maybe one-to-one, one-on-one, we'll be knowing who your teams are. And so I can be reaching out to you, and the other member of this team, Kathy Wire, also can be reaching out to you to see if you need any support for this. And then some more details is that we will be alternating the webinars. We'll start off in December with a cultural, and then we'll go into a clinical at the end of January, and then we'll alternate off and on like that. The cultural topics will include leadership, teamwork, and communication, all vital areas that really help to drive the culture. Our clinical topics included will be respiratory compromise, COPD, and high-risk transition. And we're reaching out to some of our partners who have experts in these areas. And so we'll be looking at these guest speakers to provide these webinars. And we'll be able to give you more information on that here in another week. So the patient safety forums are in person. They're going to be a half day in length. These forums are basically TED Talk style topics on culture. And it's also going to be breakout sessions then. As we introduce certain concepts of culture, it's going to have little breakout sessions. You're going to have time to engage with your partners. You're going to be able to start evaluating what your current relationship is, what your current way is of handing off patients, and maybe begin identifying some current barriers or frustrations that anyone along the continuum of care may have with handoffs, and what seems to be missed and what seems to be dropped. And then we'll also be providing you at this time a workbook with templates of multiple different tools. What we understand is that each organization is very different, and what works for large healthcare systems may not work for small rural hospitals. And many of standardized templates that come out from large organizations, quality organizations, sometimes have been developed within with the healthcare system, the large healthcare system in mind, and it doesn't quite work for CAH hospitals or small rural ones or EMS or home care or long-term care. So what we're hoping to do is provide you just with the template or the foundation, and then we can move forward throughout this project to help you develop some communication tools in the template. So then the final component of this project will be sustainability. And that will be a final webinar on ways to help keep any progress that you've had going. It'll be discussion of tools developed from your work along the way. We'll be doing some site visits during the month of May, and this will be an opportunity to meet with the team to kind of go over any questions that you might have to continue this project going forward or to keep those. And then it'll be an opportunity to identify actionable items to keep that relationship open and those communication lines going. So why transitions of care? And I have to share with you, I have a daughter who runs track and cross country, and I was a track coach's daughter. So I thought this picture of a handoff was perfect. Transitions are handoffs. It's the process of transferring responsibility for care. It sounds really simple, but is it? When you look at this picture of the sprinters and the relay team handing off the baton, you have the incoming runner handing off the baton, the outgoing runner is receiving it, and they're doing this all while running as fast as they can. The outgoing runner receiving it without looking back, and they have to do it without dropping the baton. And when you think about it, the concept of handoff, our patient is the baton. And so what we need to think about is, as you look at this picture, is handing off a baton in a relay team doesn't just happen. It takes a lot of practice. It takes communication. It takes being able to read the runners, watch the runners, get your steps in line with each other, knowing at what point in time to start taking off from the spot where you're standing, to get yourself up to speed so that you can receive the baton from the incoming runner, but you can't go outside the box that you're supposed to stay in. So this takes a lot of communication and practice. And that's kind of what we're going to focus in on, is that leadership, communication, and teamwork aspects, so that we can pass the baton or pass our patient from one healthcare area to another without dropping the baton. And these are just some areas, when you think about it, they're intersections and so places of risk, places where the baton could be dropped. I'm not going to read them all off to you, but when you think about it, these are all areas where EMS agencies might be taking a patient to, or hospitals might be handing off to, or long-term care facilities might be handing off to, and all of that requires a handing over of the baton. We know that collaboration is necessary for transitions, and we know through the research that poor handoffs result in delays in decision-making, therefore leading to delays in medical intervention, and also leading to loss of data and information. And when you look at it, transitions are becoming more complex because patients are becoming more complex. There's an increased number of handoffs. There's an increase in number of options for post-acute care. It's no longer just a patient goes to the hospital and is discharged home. They can go to an LTAC facility. They can go to a rehab facility. They can go home to home health care. And in between all of this, you have patients who you have to utilize EMS to take to those areas. And so we know that successful handoffs require effective communication. We also know through the research that 80% of adverse events cite ineffective communication as a contributing factor. So let's think about what communication really is. Communication is the process by which information is exchanged between individuals, departments, or organizations. There are 4 vital components of effective communication. The communication needs to be complete, it needs to be clear, it needs to be concise, and it needs to be timely. And so these are some of the things we're going to be looking at as we go more in depth in communication. We're also going to look at how communication plays into culture. And I'd kind of like to back up a little bit here because some of you may have heard of these different culture frameworks, some of you may not have. So as hospitals especially have been given incentives to really work on their culture, it's in a lot of it through reimbursement, and I know now that reimbursement incentives have gone over into the long-term care world, and it's also gone over into home health care with value-based purchasing. A lot of the hospitals or acute care areas have looked at what type of framework can I use. And so I've listed 3 different cultural style frameworks that have really been brought into the hospital world at least, and that's the Comprehensive Unit-Based Safety Program, or CUS, which was developed by Johns Hopkins, the Just Culture framework, which was developed by Dr. James Reason, that has been put together in a tool or a product that's put out by Outcome Ingenuity. And then lastly, Team Steps, which was developed by the Agency for Healthcare Research and Quality and also the Department of Defense. And even though all 3 of these frameworks are designed for working on culture, the one thing that they all truly have in common is that they have a foundation of communication. Some of them have specific communication tools and techniques to use in different situations. Others really drive the concept of transparency and communication, but in all of them, in some way, shape, or form, use communication to help drive the culture forward. So this is one of the reasons, that we're going to look at communication as a foundational component. And then as we look more at culture, we're going to be looking at this communication, and we're also going to be looking at leadership, because leadership really is the role model for helping to drive a strong culture. And then we're going to also look at teams, because healthcare in general, really we are teams. We're all in different arenas, but we all have to collaborate and work together because we're here for the patient. And so as we've had different specialties develop over the years, we've kind of all gotten into our silos. And several years ago, hospitals were really working on knocking down the barriers inside hospital walls. But what we haven't really focused on until recently is how do we break down the walls between all of us? How do we get to realize once again that healthcare is not just hospital in this corner, long-term care in this corner, home care in this corner, and EMS kind of out on its own? We need to realize that as healthcare providers, we are all part and parcel of one large team providing care to the patient. So as you can see here on this scale, a facility that doesn't really have the culture yet, or maybe it's just at the beginning point, maybe they've recognized that they need to work on things, they'll understand that, wow, we really have a lack of communication. Our leaders are kind of off in their offices and don't come down to see what's going on in the front line. And we don't really seem to work together as a team. There's policies and processes, but they don't always work. So we'll just go and do it the way that we know it works, and just we won't tell anyone about it. Whereas in the organization that has more of that positive culture, they evaluate their communication. Where does it drop? Am I telling you something, and are you hearing it? Can you repeat back to me what I said so that the communication is clear? Are leaders engaged? Are they coming down and looking at the frontline staff? Are they seeing what's going on? And are teams working together? If the policy or process isn't working, are they coming together and saying, okay, this isn't working. What do we need to do to change it? Where is the breakdown in this process? So, and then talking about leadership, because leaders really kind of help drive things. Culture really comes from leadership down. They're seen as the role models. So Kotter, in his book called Leading Change, which is a great book. It's old, but he's got a lot of great ideas that he breaks down into really simple concepts. So he says leadership is a set of processes that creates organizations in the first place, defines what the future should look like, and then leadership and leaders inspire people to make it happen. So leaders are establishing that vision, and they're leading by values. They're aligning people, they see where people's strengths are, and they group them together, and they help to build commitment. They are constantly motivating and inspiring people to overcome any obstacles to help bring about change. And leaders promote open dialogue, and they communicate more in action than in words. It's your body language. It's your willingness to come down and see what's going on in the frontline staff, willingness to come down and say, do you have the resources and tools that you need? It's being able to, for staff to come in and talk to you, and your body language saying to them, I value you as a team member. I'm certain we've all had the feeling where we're trying to talk to someone and they just have their head down and they're looking at their phone or they're working on their computer, and it seems like you really have something important to say to them, but it feels like to you they're not valuing what you're saying. So as leaders, we need to make certain we are valuing whatever any of our staff are saying, and our body language needs to also say that. So leaders need to be engaged, and both in the C-suite and senior decision makers, they need to also see safety not just as another program, but as a strategy on priority. They need to make certain that work life and working conditions are optimal for their staff. And what's so important, and I think especially in small rural areas, because I actually live in a small town and grew up in a small town, leadership helps to build those partnerships with their patients and their families and let them know that they are concerned about them and the care that's being provided to them. So moving on to teamwork. Teamwork is defined by Thalles as two or more people who interact interdependently with a common purpose, working towards measurable goals that benefit from leadership and maintain stability while encouraging honest discussion and problem solving. So that kind of sums up what a team is. You're working together towards a common goal, which is the care of the patient and helping the patient to improve. And leadership is helping to drive the team. And the team is always stable, and they're always open and willing to discuss issues. Healthcare, by definition, as I mentioned before, is a collaboration of multiple disciplines working together for the patient. We know from research that lack of communication leads to adverse events. We also know from research that teamwork not only increases patient safety, but it also increases job satisfaction and decreases burnout. Teamwork has become such an important ideal that the World Health Organization put out a multidisciplinary patient safety curriculum in 2011, and that curriculum encourages the education of healthcare providers on the principles of teamwork early in their education. So they're recommending that nurses and doctors and respiratory therapists and physical therapists, whenever they're going through their education, the components and ideas and concepts of teamwork are included and built in as a foundational component. So we've kind of talked about transitions as to why they're important, some of the cultural components that are important. I'm going to go into respiratory compromise. And I think I've mentioned one of the websites I've used and we've received information about through some of our providers or through our partners such as Medtronic is the Respiratory Compromise Institute. And if you get a chance, you should really look up their website. They've got a lot of information. But basically, respiratory compromise is the second leading avoidable patient safety issue in the U.S. right now. It's the fifth top condition leading to increased hospital costs. We know that more than 60% of arrests brought on by respiratory compromise are actually potentially avoidable. We also know that COPD prevalence and deaths are expected to increase over the next decade. So respiratory compromise is basically a state in which there is a high likelihood of decompensation into respiratory insufficiency, failure, or death, but in which specific interventions might prevent or prevent decompensation. And I know some of this seems like I'm really going overboard and preventing and not really going into details, but we do have some really in-depth webinars planned for you guys, and I think you'll find them really interesting. We know that approximately 14 out of every 1,000 hospitalized patients experience respiratory failure following surgery. We also know that respiratory compromise increases a patient's mortality rate by over 30%. And we know that respiratory compromise also increases ICU stays by almost 50%. What we're trying to do is that we've noticed that respiratory compromise has had an increased awareness nationally. And this is because it can be a big indicator and is often the first indicator of an impending decline in condition. There's many contributing factors towards respiratory compromise, one of them being COPD, which we're going to go over, asthma, community-acquired pneumonia. And one of the reasons why I put in asthma as a large contributing factor is what we are seeing in the community is that asthma was once really thought of more as a childhood disease, but we're seeing more and more cases of adult onset asthma, which does then make them at risk for respiratory compromise. But the biggest takeaway I really want you to get today is that it is preventable in many cases. And so COPD is also, as mentioned earlier, the prevalence is really increasing. It is a contributing factor to respiratory compromise. COPD can be an underlying cause of cardiac arrest. And then also, according to WHO, not only is the prevalence increasing, but deaths due to COPD are estimated to increase 30% or more over the next 10 years. And one of the reasons why I think this topic is really important, and we were talking with one of our partners recently. But patients with COPD are actually very medically fragile. And I think maybe due to the increasing prevalence and because we're seeing it more, that we've kind of let ourselves become a little lax and realizing and keeping our awareness up to the fragility of these patients. They are susceptible to pneumonia, flu, and cold. And when they do become ill with the above, it's not just their respiratory status that declines, but their cardiac output also declines. And so that makes them susceptible to cardiac issues. And then the other thing with our COPD patients is that because of their medical fragility and sometimes having to be confined to their home, they have an increased susceptibility to depression, which can lead to other issues. So with COPD, what I'd really like to do in this project with all of y'all is to have an increase in the awareness of complications that arise from COPD, an increase in any education, and then really understand how this type of patient really needs that collaborative care team in the community. EMS agencies really do need to be aware of who their COPD patients are. I think it really helps if you get a call to a home and you know beforehand, oh my gosh, I know this address, it's on a list of like priority 1 patients. They have COPD, they have oxygen at home, they're a pretty fragile patient. So that helps you in preparedness of going on the call. Likewise, the primary care physicians need to know. Long-term care facilities are many times involved with the rehab of these patients after they have a pneumonia or they have an exacerbation. Many times these patients will go from the hospital to a skilled nursing facility specifically for pulmonary rehab. So that need for collaborative team in the community and effective communication across this team is really needed and vital to keep these patients functioning at optimal independence in their homes. So to kind of summarize, this project is going to cover some clinical areas, going to cover some cultural areas. Our goal is really to get that engagement in the community going of health partners, to identify areas of improvement in handoff, to have you all participate in webinars about clinical challenges regarding the handoffs of high-risk populations, to work together in the development of a handoff tool. I want you to look at it as an opportunity to increase your knowledge base on these clinical challenges and to also increase your awareness of the cultural influence in transitions and handoffs. The team at Center for Patient Safety is pictured here. Kathy Wire and I, Tina Helmuth, will be leading the project, but we will also be bringing in Lee Varner, who's our EMS expert, on board to kind of help with EMS. And then Alex Christian, our executive director, will also probably be helping along with Jennifer Lux with some of our surveys on patient safety. And then Shelby Cox, we don't have a picture of her yet, but she will also probably be helping a little bit with trying to reach out to EMS. So those are kind of the team members that are at the Center for Patient Safety. Here are our email addresses if you would like to reach out to us with any questions. And then I'm open for any questions. And I will actually turn it back over to Karen here.
I do have just a couple questions that were sent to me via chat. The first one is what if I cannot recruit a nursing home facility? Can I still participate? And I go ahead and take that one, and then you can chime in, Tina. Ideally, we would like every hospital to recruit a nursing home facility as well as an EMS facility. However, we do recognize that there may be unique challenges as to why you might not be able to get that accomplished between now, and throughout the project. So with that said, that we want you to continue to participate with us. I think that there's going to be some great information, and because, as we said, we recognize that there's going to be different points in the journey for each community. So we want to meet you where you are and recognize that, maybe in the middle of the project, you may be bringing on others to join us as you may be, feel more comfortable. So the next, Tina, anything you want to add to that?
No, I agree with everyone, everything that you said. We realize that you might not be able to bring someone on board. We do have some people who have worked with some nursing homes in Indiana, so we might be able to help you. But either way, I'd like you to still participate because there's a lot of good information. And then as you maybe go forward and do find a partner, you might be able to share with them, and then they can provide feedback on any tools that you've worked to develop.
Yes, and that ties in very nicely to the next question. I've never asked anyone to participate in a quality improvement project outside my organization. Can you assist me? And the answer to that is yes. We welcome the opportunity to set up, a one-on-one call, maybe to give you some coaching ideas and tips, or if we need to set up a call with the nursing home, the skilled nursing facility, or the EMS, or your triad together, we would be happy to do that as well. So please know that we're here for you as we go through this project. I don't see any other questions in the chat. I guess before we answer have any more questions, I did want to introduce Abby Garcia. Abby is the State Office of Rural Health Manager, and actually is our point of contact with the Office of Rural Health for SHIP. So really pleased that Abby is able to join us. I think Abby would like to say a few words before we have any more questions or adjourn.
Can you hear me, Karen?
Yes.
Okay. I just wanted to thank everybody for participating in this kickoff webinar for this project. I am really looking forward to all of the projects that we have going on with SHIP right now. This is just one of 6, like Karen mentioned. So in the coming weeks, be looking for a Survey Monkey to get some feedback about the application process. Our new SHIP year, actually the competitive year for the grant is coming up very soon. And so we want to make sure that we can do that as smoothly and as efficiently as possible for everybody. And I know that the transition from the individual grants to this big kind of cohort experience was not without its bumps in the road, but I just appreciate everybody for sticking with us and supporting these educational opportunities. I'm just really excited to see what this first year brings in each of these projects. So thanks for having me.
Thank you, Abby. Do we have any additional questions? I will mention, Tina did go over this, but I just wanted to reiterate it. If any of the participating hospitals have completed the culture survey with IHA, we will work with you to get that information into this as part of this project. We certainly do not want you to have to repeat that culture or patient safety survey unless you opt to do that yourself, and that's not going to be part of the project that we would ask you to do that. If we would ask you to do that survey is if you haven't completed it since January of 2017, so looking at about a little over an 18-month period, and I really actually don't think that there was any hospitals that were impacted by that, because it is recommended that you do that survey at least every 18 months. And then the other is Tina mentioned that we will be having those 3 patient safety forums. And so we did, through getting contact information from the hospitals, ask if you were willing to host one of those meetings, and we did get some volunteers. But certainly, if you are interested, please let us know. So if it's maybe not in this round, we'll definitely get you on a list that you're interested in hosting a meeting. So thank you for those who have, so that they're interested. We have recorded this webinar, so it will be available. Should you want to send it to others in your organization, or if you want to forward it to a potential skilled nursing facility partner or an EMS, that will be available to you as well. Anyone else have any questions? Okay. Well, please, for the participating hospitals, please look next week. We will be following up with some information that will include the PowerPoint. We'll also be including a list of all the participating hospitals because we do want to start creating that community forum and the network for this project. We will be asking some information to know who you're thinking about having join us in this project, or maybe who you actually have asked and have some commitments from. And so then, so please be looking out for that information in the upcoming week, as well as a summary of the project and our contact information. So if there aren't any other questions, we will go ahead and adjourn for today. And I really appreciate the opportunity to be speaking with you, and look forward to be working with you throughout now and the upcoming months and through the end of May of 2019. So thanks so much, and I hope everyone has a great weekend.